Good morning. Welcome to Brief Lessons in Emergency Medicine and Trauma. My name is Ismail Kubera and I'm one of the attendings here at Jacobi. Today, we wanted to discuss a little bit about head injury and which patients of those need further imaging. Now, throughout your career, you're going to see tons of people with head injuries. Some of these will be obviously sick. These patients will need emergent airway management and fast resuscitation. And others will be reasonably well appearing, walking around your emergency room. The patient who is pedestrian struck or hit over the head with a bat with an obvious skull fracture necessitates a CT with little conversation. The other side of the coin, the patient who's reasonably well and walking around your emergency room, poses a different problem for emergency physicians. So, how do we decide on which one of these patients needs imaging? As it is, we already CT many people. Over 1 million head CTs are ordered in the United States, but fewer than 60,000 of these are found to have any significant brain injury. In 2001, a group from Canada led by Dr. Steele tried to come up with a rule to help us make these decisions. It was a prospective study over 10 Canadian emergency rooms. They enrolled over 3,000 people and looked to see if they could determine which factors were high risk and medium risk to help them decide in the future who really needs those CTs. The rule determined that high risk was a GCS score of less than 15 2 hours after the injury. They also found patients who had a suspected open or depressed skull fracture, any sign of basal skull fracture, like CSF otorrhea or battle sign, vomiting greater than 2 episodes, or older age, that age greater than 65 years old. They then came up with some medium risk factors. The medium risk factors they found were amnesia before impact of about greater than half hour, or a dangerous mechanism like being ejected from a vehicle. They found that if a patient had a high risk factor, they had a very high sensitivity for having a brain injury necessitating neurosurgical intervention. They found that those people with medium risk factors also had a high sensitivity for finding anything on their head CT. So essentially, if a patient has any of these, whether high or medium risk factors, they should get a CT in your emergency room. There are another couple of groups came up with their own rules, and I think these rules needed a little bit of discussion. A group from New Orleans came up with the New Orleans criteria. They said that CTs are required for patients with minor head trauma if they had a headache or vomiting, if they were older and they specified an age greater than 60, if they were intoxicated or on some other drugs, if they had persistent anterior grade amnesia, or if they had any visible trauma above the clavicles or a seizure. That trauma above the clavicles kind of is very inclusive, and that's maybe why their sensitivities were so high. A group that you may know from their CT C-spine rules, the Nexus group, also had a set of rules. They found that if their behavior was abnormal patients, if they had any emesis, if they were older, age greater than 65, if they had any neural deficits or bleeding disorders, if they had an altered level of consciousness or a skull fracture or a bad scalp hematoma, these patients also needed CTs. So what do? You have these 3 rules. Which one is better than the other? Over the coming years, there have been several articles that looked at all 3 sets of rules and compared them for sensitivities or reliability, reproducibility, and the data points vary. So what do? I think that our best bet is to find one rule. Take one rule you like, learn it, and use it. Now, this should never replace your physician gestalt. As you progress in your career, you'll get a sense of who really needs that, despite not meeting every rule in the Canadian or the Nexus criteria. Take these, learn them, and good luck in the rest of your career in emergency medicine. Thanks.